Welcome everybody today to the SOAR Echo series. Today we have Rachel Cooper, who's going to talk. She's from Sanford Health, and she's going to do a talk on Eat, Sleep, Console. She was actually at the perinatal conference, and it's a great talk. So really happy to have her here today.
We have some great upcoming presentations. You can see on the slide. I won't bore you all with reading them.
Yeah, a lot of good ones coming up. So remember, there is free CME. Please fill out that thing that Katie sends you. If you don't get the credits, and print those out and keep those. So the other thing, of course, we love it if you turn on your video, unless you have a small baby, then we'll give you a break. But yeah, it's just much nicer for Rachel if she can talk to people and not black boxes. So
Kurt recently transitioned over to almost being a vegan after watching the Netflix series. So he needs some new lunch ideas if anyone wants to share while they're on video.
I'm eating way more vegetables than normal. And I don't know. I don't know how this is going to go. We'll see. Remember, if you need technical assistance, please feel free to reach out. Give Erin a call. She's probably the most available. If you need me, my phone is there as well. And we're happy to help you with any of the issues that you have. We get a lot of interesting phone calls. So next slide.
And then Stratus Health houses the core website, and it's an excellent place to go for any resources that you may need. Don't reinvent the wheel. Check it out.
And there's our talk, and we will let her share her screen. So Rachel, if you want to introduce yourself and tell us all about what you do, that'd be great. And then we'll let you share your slides.
Great. I'm Rachel Cooper. I'm a pediatric hospitalist. I work up in northern Minnesota at Sanford Bemidji. And I come by my interest in working with families affected by substance use and misuse in a few ways. One is that the community that we serve up at Sanford Bemidji has a very large Native population. And as many of us know, the Native community and many marginalized communities are disproportionately affected by substance use disorder. And with that, we see a lot more babies than most places do that are born with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. My background prior to medical school is I went to graduate school for bioethics. So most of my research and sort of extra clinical activities have been in the realm of bioethics, which certainly this fits into well. And then in addition to that, I'm also the faculty lead for the MOSTAR initiative, which is through the Minnesota Perinatal Quality Collaborative. It's a statewide QI project on improving care for families that are affected by substance use disorder in the perinatal period. You may hear my 6-month-old son in the background chattering away, but hopefully he won't be too disruptive. And, so Eat, Sleep, Console is something that has been around since about 2017. The first publications were put out there. I think our experience with implementing Eat, Sleep, Console is quite interesting, given that we're not an academic center, we're a community hospital. And, we have a much larger proportion of infants that are exposed to opioids than most places do. And so, implementing Eat, Sleep, Console is one thing when you have 1 or 2 babies in a larger nursery, and you have a lot of resources to dedicate to each one and to each dyad when it's going on. There are some particular challenges that happen when you're implementing Eat, Sleep, Console, and you have a very high volume of babies that would fall into the category of ones that you would manage this way. But I also think that our experience has been extra challenging, but also extra rewarding because of that. And we've been, unlucky / lucky to be a bit at the forefront of some of the newer things that have come up. So more and more fentanyl exposure, more and more babies that are actually actively withdrawing or actively affected by fentanyl in labor and then actively withdrawing after that. We have now had 2 cases of babies that have tested positive for fentanyl laced with xylazine, which is a veterinary anesthetic. And that's been in the news a bit recently because there have been some overdose deaths across the country of people using fentanyl that's laced with xylazine. It is a alpha 2 analog. And so our best sort of guess at how to help manage babies or anybody else withdrawing from it is to use clonidine. But, you know, we've had 2 babies so far that we have been weaning off of morphine after that exposure. And I've never had babies harder to wean than those ones. And I, you know, spoke with colleagues in Minneapolis and Fargo and Salt Lake City, and none of them had seen it yet. So a lot of it is sort of figuring out as we go along how to manage things.
Rachel, you might be covering this in your talk, but how are you testing for xylazine in your facility?
So we are testing in cord blood. I believe that we may also have confirmatory urine testing for it, but we're also testing in cord blood. And I don't know how long we've been sending it.
And where are you sending it? Do you know?
I think we're sending it to Mayo.
How long does it take to get results back on that?
Like a week and a half, 10 days. So, both of these babies have been significantly harder to wean and struggled with feeding and weight gain in a way that is a bit different than the typical. So neither one of them were we surprised when it came back positive, especially the second one. Those are all great questions. Though I actually spoke with my cousin who's a veterinarian about it, and she was saying there is an antidote. There is a reversal agent, but it's not available for humans yet. And they are also very worried that their xylazine is going to get pulled for veterinary uses because of this. So yeah. Well, I will share my screen and get started. All right. Can everybody see the slides? I can't.
No, we don't see it yet. No.
Oh, okay. One sec.
I'd like to pretend I'm the tech person here, but that's Katie.
Mm-hmm.
Yay,
there we go.
There we go.
There we go. Okay. So slideshow. All right.
Beautiful.
Perfect.
Great. All right. So Eat, Sleep, Console. Yes. Okay. So Eat, Sleep, Console, again, it comes out of a group of pediatricians, principally Dr. Grossman at Yale, and was first sort of published on in 2017. And the idea is that babies have 3 jobs. They need to be able to eat well enough to gain weight appropriately and stay hydrated. They need to be able to sleep for at least an hour after feed. And they need to be able to settle within 10 minutes. And that is in contrast to the traditional scoring system, which is the Finnegan scoring system, which we'll talk about a little bit. But this is all in the context of sort of, instead of jumping immediately to pharmacologic treatment, and particularly instead of jumping immediately to separation of the maternal infant dyad, that we are trying to preserve that and use that as our primary treatment strategy, use those non-pharmacologic interventions. So neonatal abstinence syndrome, as most of you are probably aware, refers to physiologic withdrawal from chronic substance exposure. So, we do have parents that worry about, are the 2 doses of fentanyl I got before I got my epidural gonna give my baby withdrawal? No. is baby, if mom's under general anesthesia or getting, opioids otherwise, you might see a baby that's a little sleepy for a little bit after they're born, on the order of minutes but that's not going to cause significant withdrawal. A lot of substances can cause withdrawal that are not opioids and that aren't illicit substances. So nicotine, SSRIs, caffeine, alcohol. I've only ever seen one baby that actually withdrew from alcohol. We know that exposure is not rare, but withdrawal actually is quite rare. The one baby that I saw that had significant withdrawal also had a bunch of co-exposures, and mom had admitted to, I think, having 8 beers a day. So very significant exposure. One of the things I want to highlight about things like exposure from medications and a little bit of withdrawal in that regard, or even caffeine, is that I'm a huge proponent of mom's mental health is really important for the health of the baby. So women are often sort of willy-nilly told that they either can't breastfeed or they can't be on their meds during pregnancy. And it's so irresponsible to do that. They just need to be counseled on, hey, we might see 24 to 48 hours of a little bit of jitteriness. Maybe baby might have a little bit of tighter muscle tone or other things, but generally those are self-limited, and that the benefit of being, the healthiest, happiest mom that she can be on, or that mom can be, is going to outweigh the risk. Need to rule out things like sepsis or hypoglycemia when you're seeing symptoms, but otherwise generally pretty short-lived. It can cloud the clinical picture to have several different substances that that mom is on, whether it's a combination of prescribed medications and non-prescribed medications. So sometimes there's a bit of teasing things out that has to happen there. Neonatal opioid withdrawal syndrome refers to specifically physiologic withdrawal due to chronic opioids. And it's helpful to separate that out because you really don't see physiologic withdrawal from things like cocaine and amphetamines. So when we're talking about separating pharmacologic and non-pharmacologic treatment, we really should not be treating methamphetamine withdrawal with morphine. And it is a thing that you see people doing, and it doesn't make physiologic sense, nor is it necessary. Opioid withdrawal always requires non-pharmacologic treatment. It sometimes requires pharmacologic treatment as well. I'm just trying to dig out a passy. Here we go. And that's really a paradigm shift. Historically, babies have sort of been started on morphine right away, put on monitors, and sent to the NICU, which is obviously disruptive from a bonding standpoint. But even medically, it is very obvious, even with our nurses who are unbelievably skilled in caring for babies with withdrawal, they just respond differently to their parents. It's just different. So signs of physiologic withdrawal. I am very careful and am a proponent of being really intentional about language. So it's not addiction. It drives me nuts when people talk about babies being addicted to drugs, because they're having physiologic withdrawal. That is what's going on. So, when we're talking about things like we were talking about earlier with medications, it's often sort of mild jitteriness, hypertonia, etc. We talked about looking in LactMed or Hales if, in pregnancy and breastfeeding for safety. And pretty self-limited. With opioids, the onset tends to coincide with the half-life of the opioid. So, for example, fentanyl is really the only one where, I have had babies within the first hour of life that you're sort of teasing out, is this fentanyl withdrawal? Is this sepsis? Is this true respiratory distress, or is this withdrawal? But generally, when we're talking about buprenorphine, or we're talking about, so heroin will have a faster onset, more on the order of, getting close to 48 hours. With Suboxone, it's often in that like 60 to 72 hour range, but it can be variable. Methadone, given the even longer half-life, tends to be even a little later than that. There are institutions that tailor the sort of minimum period of observation for the baby to what they were exposed to. I tend to think it's easier to just set a like 5-day timeline minimum for everybody when you have an opioid exposed baby, because it can be really variable, and it's not always totally dependent on, what mom was using or how much. And I think it just keeps things cleaner to just always sort of say 5 days. And if baby is sort of on the downswing as far as symptoms, then we're good to go if they haven't needed any pharmacologic intervention. It is very helpful to outline the timeline with families well in advance and to keep reinforcing it, because we do see a lot of families, particularly ones that are very reticent about using pharmacologic treatment. We do see a lot of families that are like, well, it's day 2, baby looks great. It's dumb that we have to sit around here for 5 days. And so we talk about, one of the reasons that Suboxone or methadone are really good medicines for folks that have struggled with substance use disorder is because they're slow on and slow off. And so for babies, that withdrawal tends to be slow on and slow off. And we want to make sure that when we're sending them home, mom can feel, or whoever's taking baby home can feel really confident that things aren't going to get worse. And in general, the principle is always functionality and a baby that can do their job rather than a totally asymptomatic baby. So we talked a little bit about the sort of traditional paradigm, which is Finnegan scoring. As you can see from this grid on the right side, it's very complicated, and it was invented in the 70s by Dr. Loretta Finnegan. And a lot of it is based on, kids, for example, that went through open heart surgery and are on opioids for a very long time and being weaned off of them. It is onerous to perform. A lot of, our nurses who have done this a tremendous amount can do FIN scores in their sleep, but, it is a certain amount of work versus Eat, Sleep, Console. Generally, the sort of threshold for treatment has usually been a score of 24 over 24 hours. So either 3 scores of 8 or 2 scores of 12 is often what people talk about. And you can see that some of these symptoms are, nasal stuffiness, sneezing, frequent yawning, loose stools. And when we get into treating those with opioids, we can really start over-treating. And then once we're treating with opioids, we can cause some iatrogenic withdrawal as well, because if we're really slow about weaning them based on the baby's scores, the slower you are, the harder it gets to wean them. So Eat, Sleep, Console, like we talked about, based on these babies' jobs. And when they've looked at in recent studies, when they've looked at if you do Eat, Sleep, Console scores and FIN scores, do you miss babies who otherwise need pharmacologic treatment? And the literature would say that you do not, that you will identify the babies that really need it just by doing the Eat, Sleep, Console scores, and you don't need to do FINs. The vast majority of time, that has been my experience as well. I will say I have run across a couple of babies where they're scoring zeros on Eat, Sleep, Console, but they're getting 11, 12, 13% down in weight, and they're taking plenty of calories, and they just will not gain weight. And we've tried PRNs, we've tried other things. We've fortified their formula or fortified mom's breast milk to 24 calories. We've done everything and they're just not gaining weight. And so I have had a few that ended up needing it despite having low Eat, Sleep, Console scores. Most people that I've talked to haven't really experienced that. I think the other thing that potentially maybe contributes to that in our context is that, you know, we're always short-staffed and we often have 6, 7 babies that are on the Eat, Sleep, Console protocol and going through withdrawal. And not many of our moms are in a position where they're able to board at the hospital the entire time. Mostly because they don't have the social support that would empower them to do that, which is really not fair. And I think that both lengthens our lengths of stay just because there's only so thin you can stretch a nursing staff. And I think it means that sometimes we end up having to go back to the FIN scores. Or for example, preemies, we do FIN scores for babies that are born before 37 weeks because preemies don't always show symptoms in quite the same way. And they may have feeding difficulties for other reasons. So those are sort of the complicating factors there. Non-pharmacologic care needs to be standard for every baby. And so, you know, low lights, quiet voices, minimizing electronics. And one of the things that I think is really empowering about Eat, Sleep, Console with this is that it really gives the caregiver a lot of tools, and it emphasizes that they are the most important part of their baby's treatment. That we are sort of there to help support and provide medical things and guidance. But, you know, for example, we provide journals for the moms to write down like, okay, these are the things that seem to work really well for my baby. These are the things that seem to not work quite as well for my baby. And that's really important. So that all goes along with preparation for the family, which is hard, especially, we have a lot of birthing people that prior to delivery aren't getting prenatal care, in some part because of how crappy the treatment often is of people with substance use disorder, and a lot of the fear around that, and a lot of the discrimination that is very well-founded. And so we were working on that, but, by really preparing them for what it's going to look like in the hospital, particularly if you have someone that's been on their program for a long time and they've had babies under the more traditional NAS management protocols, that kind of talking to them about the ways in which things may be different this time. And I've met a lot of families that have had several babies while mom's been on her program, and universally they like Eat, Sleep, Console much better than the traditional management. And part of the importance of that talking and, exploring what this is going to be like before they get in the hospital is also emphasizing, and I do this when they're in the hospital as well, that them staying on their medicine is the safest and best thing they can do for their baby. I recently had a mom who self-weaned off her Suboxone after 2.5 years sober, in about month 3 or 4 of pregnancy, and then had a full-blown relapse a couple weeks later and ended up in a pretty disastrous situation. And so, and she said, I wish I wouldn't have done that. And there always comes a point, especially with babies that have significant symptoms, where moms say, boy, I really wish I could have just gotten off this medicine. And it's really important that we remind them that, yes, this is really hard right now, but you are doing the right thing for your baby by staying on your program, and we can get baby through this tough period, and you can get baby through it. But you are doing the right thing by being on your program, and we want to make sure you know that, and we want you to know that we know that. And I can't say that doesn't mean that significant judgment isn't sometimes telegraphed to our moms anyway, and I find that infuriating. But I think emphasizing both with staff and with families that like this is the right thing is really important. I also think transparency prior to them coming to the hospital is really important. So if the hospital has particular policies about, or the state that you're in has particular policies about child protection holds, about drug testing, all of those different things, one, they're all worth revisiting and making sure that we're doing them in the most equitable, responsible way possible. But in the meantime, transparency is really important. Particularly with the new legislation around mandatory reporting of substance use in pregnancy, that's a step in the right direction in order, not one sec. In terms of building trust with families that we don't have to report if women are engaging in care, but the definition of engaging in care is not real clear. Different people feel different ways about it. So families just need to know sort of what the state of things is and what that could mean. The other thing it's really important to me to be clear about is this does not mean we don't do pharmacologic care anymore. And it doesn't mean it's 5 days and you get to go no matter what. And pharmacologic care is not a failure. I think Eat, Sleep, Console helps because we generally start with PRNs now, and it gives us a chance to say, okay, if your baby just needs 1 or 2 doses, then they're just going to get 1 or 2 doses. Whereas a lot of these moms are very used to sort of the minute that train starts, they know they're in for a few weeks stay at the very least. So the way that the workflow is that if babies score a 1 more than twice, we do a team huddle, and that includes the parent. Hi. Yeah. You've never seen screens really, so this must be kind of exciting. And that includes the parent soliciting their insights. And then if we're scoring 2s, generally we have a team huddle with the provider and with the family. Really important to, like, when you're doing physical exams or you're talking about scoring, to explain what you're doing and why you're doing it and what you're seeing, and ask the parent if they're seeing it, which seems like it should be obvious, but we have a lot of parents that say, I have no idea what they're talking about when they're saying tone and they're pulling on baby's arm and letting it bounce back. And, it's really important to explain what they're doing, both for understanding and because it can be really traumatic to see someone poking and prodding at your baby and not know why. And so the outcomes as places have transitioned to Eat, Sleep, Console, and this was a study from a community hospital in 2019, showed a 79% reduction in exposure to morphine by dose, cumulative dose, reduced cost, so 48% reduction in cost, vastly improved patient experience, and then very much improved lengths of stay. So like this was sort of a win on every front for both hospital systems and families. I will say our hospital has not seen the reduction in length of stay that a lot of hospitals have seen. And I think that's both because of the level of exposure and of co-exposures that we have. It's also because of just being stretched really thin, that like we both have a community that is marginalized in a way that is extremely profound. So less parents that can stay in the hospital when it's starting to become 2 weeks, 3 weeks, 4 weeks, 5 weeks, which is much longer than average lengths of stay. And it's not to say that most of ours are, but some of them are. And when the parents aren't able to be there, then, baby unfortunately sometimes requires more meds, which then takes longer to wean. When you have nursing staff that is really stretched thin and they're doing their absolute best, but they can't be sitting there holding the baby all day in the way that mom can, that complicates things. We do lean on volunteers when we have them. We often, our resource nurse will pop in. We do our best, but the reality is it's hard when you don't have parents at the bedside. And there we go. Sorry. And there are significant challenges, like we talked about, beyond the resource concerns that we have, things like resistance to change and letting go of control. Like particularly our nursery nurses are so skilled at helping these babies eat and at managing them. And it's sort of releasing them more into the care of their parents and having the parent drive the care and letting them be a little bit symptomatic feels very uncomfortable. There was a ton of resistance to this at first. I would say we've come a long way and most people are really on board with it. I think some of that has also been empowering them to share their insights and drive change as we've seen the things that are unique to our situation that need to be adapted, but really hard. Expectations around boarding. I am really, really happy that we've changed our border policies such that women that didn't come in on programs can still board. We try and get them on a program, but it is not contingent on them having come in on a program to be able to stay. It used to be that you couldn't board if you came in on illicit substances. You were not allowed to board at the hospital while your baby was there, which wasn't good for anyone. We talked a little bit about resistance to pharmacologic care. Along with sort of really trying to frame it as not a failure, I also believe in being really transparent about limitations to parental autonomy in general. So the way I usually explain that is like, we're going to work with you. We want you to drive the care. We want your baby's needs to drive the care. That said, if there comes a point where I feel like there's acute danger to the baby by not treating with medicine, there may come a point where it's not a choice anymore. And that's the same as it would be if, you had a kid that was in a car accident with a big broken bone. You wouldn't be able to refuse pain control for them. Same thing here. And that's a conversation that you sort of wade into. I tend to do it early, but only as needed. But I do think that when things do get tough, it sets us up for it being able to de-escalate a little bit more easily. And then safety concerns. Safe sleep and safety concerns have been really prevalent in hospitals, particularly in baby-friendly hospitals for a while. But, our vulnerable and marginalized populations do have many more safe sleep related deaths, substance use or not, than other communities do. And then you add in concerns that staff and other folks will have, around a mom that might be extra exhausted because her baby won't let her set her down. A mom that might be on both her Subutex program and 3 other psych meds that are making her maybe a little bit groggy, cultural differences, all of those things. Sometimes pressure to breastfeed that goes so far as, I think, really being harmful and sometimes potentiating some of these safe sleep accidents. So those are concerns that people have. A word about safe sleep. So, almost all SUID or SIDS deaths occur in unsafe sleep environments. And as we talked about, it disproportionately affects marginalized communities. And unfortunately, we often counsel about it in a way that isn't very helpful. And it feels like we're just sort of covering our asses in the hospital. And I think there is a way to talk about it that acknowledges how hard it is, that is empowering in the sense that it says this thing that's every parent's worst fear, you really are in control of preventing it. And just like we do with a lot of issues related to substance use, talking about harm reduction things. So, my top 10 like safe sleep tips that aren't the things you necessarily always hear. I like to talk to families about these. So this includes things like sitting on an uncomfortable chair instead of a big, soft, fluffy chair, having alternative spaces for safe sleep in your home, like empty laundry basket on the floor with nothing in it, super safe. Learning how to soothe the baby effectively so that you maybe are a little less tired and they're sleeping a little more. Setting an alarm for 5 minutes on your phone. If you're feeding and you're sleepy, no laying with a baby on a couch ever. Like if that's one thing that somebody does, safe sleep accidents are 20 to 60 times more likely to happen on couches than any other surface. So there are ways in which we can do this that are both empowering for families and that are realistic. And then I think our transition to Eat Sleep Consult also gave us a lot of opportunity to work on a lot of other issues that really impact the care that we give to families. So, there we go. So trauma-informed care, particularly historical generational trauma and mistrust that is really common in marginalized communities, and acknowledging that it is very well founded. There are very good reasons for that mistrust. Learning more about risk reduction strategies, both with respect to issues directly related to substance use, but also, with respect to feeding practices, sleeping practices, there are harm reduction principles that can be applied to everything. And even just the mindset of the perfect not being the enemy of the good, I think is really helpful. We did a lot of training on adverse childhood events and the ripple effect on long-term health, as well as the ways in which we bring our own trauma to the care that we provide. Compassion fatigue, and that ties into that, our own trauma that we bring to the table. And that's something that I've really had to check myself on, realizing that coming from a very different place than the bedside nurses do, who are seeing it and at the bedside with the families constantly and have seen just over and over and over really difficult things happening with babies, and have seen some bad outcomes, that my sort of at a distance, sometimes more theoretical experiences with that put me in a very different space than their very frontline experiences with that. And so I have to understand that when we're discussing things about a baby, and maybe they're going in a direction that I think is not helpful. And then, a quick word about pharmacologic treatment. So there's a lot of variation. Consistency within an institution, I think, is the most important thing. PRNs first are a great idea. Even if you're doing 3 PRNs 4 hours apart and you essentially just scheduled it, just the fact that you are considering whether or not the baby actually needs it, and you're being open-minded and you're walking the parent through it, I think gives you a lot of buy-in if you do need to schedule it. policies about hemodynamic monitoring. So if for PRNs, we send babies to the nursery for 3 hours after the dose. Once they're scheduled, they stay in the nursery on CR monitoring. There are places where once babies have weaned a certain number of times that they're able to go back out to the room with the family and just come in for dosing or even not. We don't do that yet, but it's something that we've talked about. We talked about how Finnegans sometimes are helpful. There are NICUs and other places where once they're doing pharmacologic treatment, they automatically go back to FINS. There are other places like us where we do eat, sleep, console unless there's a reason to do FINS. Considering an adjunct, we had really started using clonidine earlier and more often and at more generous doses. Not only for babies, for example, exposed to xylazine, because that's very new, but, we have found, and a lot of places have found that, you can wean clonidine a whole lot faster than morphine. So you're not buying the baby more than maybe 2 to 3 extra days of their hospital stay by adding clonidine, and you may actually be reducing it because often you can use less morphine and wean faster if you've got that clonidine on board. We don't use phenobarbital very often. Most places that I've seen and spoken with use clonidine first, but you can use phenobarbital. And then, the reason we like morphine is because it has a short half-life, which makes weaning easier. And because you can titrate it to sort of a functional response a little bit quicker. I have seen places that use methadone or even send babies home on methadone. I think that sort of comes from a pain team outlook that are often pain teams that are more used to dealing with, these patients we talked about with chronic pain or post-heart surgery patients or other patients where it's not substance use disorder that was potentiating the issue in the first place. We have found that we've had a couple babies that have come back from other institutions on methadone, and it's really hard to wean them off of it. And then, we observe for 24 to 48 hours after the last dose of morphine. Clonidine, we wean really quite fast. And continue to check some blood pressures and then send them home. The information in these slides are based on the Children's Hospital of Philadelphia protocol. One of the things that I've noticed over the last few years is that there's been a push that I think is great to wean faster and to discontinue earlier. You can kind of get into this pattern of chipping away at it so slowly, or like, oh, well, baby's weaned 2 days in a row, so we shouldn't wean today. Well, is baby doing badly, or are we just giving them a break sort of to give them a break? And it's a delicate balance, but also like really reinforcing that the goal isn't being asymptomatic. The goal is being functional. And that, yes, it can be a little uncomfortable to see a baby that is tremulous or hypertonic, but the longer that we keep giving morphine at the same dose without weaning, the harder it is to wean. So we don't want to create a situation where they're more withdrawing from what we're giving them than what they were exposed to. And there's some of that I think is inevitable, but that's important. And that's really all I have for you as far as things that I definitely wanted to cover. What questions or comments did people have?
Rachel, there is a question in the chat from Abby regarding bup use for babies. And is this something that is happening?
So I have not heard of people using buprenorphine for babies. I could see that maybe people would do that. Philosophically, I wouldn't be inclined to go that direction, mostly because what we want to do is get them off of the medicine. And so switching from these longer acting medicines that are really great for mom to shorter acting ones that are helpful for baby and can be weaned off, I think is a good thing. I will say we do really emphasize that if mom can pump or breastfeed, that little bit of buprenorphine or methadone that comes through in the breast milk is great for baby. And it's also not so much that you see like significant withdrawal if mom stops breastfeeding or can't be at the hospital for a couple of days. And that's actually a thing I've had to sort of educate some folks on. I've had a couple of situations where nursing or other folks have told families, well, if you're not going to give exclusively breast milk, then you're going to make withdrawal worse. And so you shouldn't do it at all. And that is just not the case. Any amount is great. And I'm, I've seen one baby where like they maybe had a touch worse withdrawal when mom stopped breastfeeding and stopped using express breast milk. But even that was super manageable, and the overall benefit is really important. I will say, marginalized communities have much lower rates of breastfeeding and pumping in general. And I think we need to support that much more. We also need to do it in a way that isn't just piling on to people who already don't have very good support, which is the key thing to being successful.
Yeah. Since we're on Suboxone, what's your experience been with Suboxone babies needing any supplement afterwards if mom's been on Suboxone long term?
Do you mean supplement as far as nutritional or as far as medication?
Medication, like, often, it just depends on what you're, if you're using Finnegan, I think historically more babies ended up on morphine. There was initial data with Suboxone that showed that it was about the same, but my experience has been that it's quite a bit less. Do you have a thought using each sleeping pill?
So given the long half-life of Suboxone, I would say it's fairly similar. And certainly there are cases where sometimes those babies need morphine for longer just because it takes longer to kind of get out of their system. But it doesn't seem to be dose dependent. Mm-hmm. Like we definitely see moms on very low doses where babies really struggle, and we see moms on pretty generous doses where they don't. And I think some of that is just baby and mom dependent, and some of that has to do with polypharmacy. Like sometimes we see moms that are on Suboxone plus gabapentin plus some benzos plus an SSRI plus Wellbutrin, and those tend to be situations where it's a little trickier.
I have a question just about your workflow. If you have a mom that comes in and she's starting to enter acute withdrawal, do you guys do a bup induction right up on your OB floor, or what does that look like? That's awesome.
Yeah, so it's a better question certainly for the obstetrics and addiction medicine folks. But yes, we do buprenorphine induction on the floor. And that's part of the thing that I've found so unbelievably rewarding about this change in policy where we do have moms board at the hospital. Yes, we have had some situations where it got dicey. We have had situations where moms relapsed in the hospital, all sorts of things. It's not always perfect, but we have also had situations where you have a mom that got no prenatal care, was using many different substances, gets on a program, ends up staying in the hospital with her baby for 3 weeks, developing this really great relationship with the baby and the nurses. And, it even sort of provides kind of a venue for them to have a supported parenting experience beyond just, the fact that baby's going through withdrawal. So yes, we do that on the floor to moms that want to. We don't make it a condition for staying, although the border agreement does have things about, if there are safety concerns or active substance abuse in the hospital, which happens with some frequency, then they, you know, they would forfeit their boarder room. And particularly moms who either are not ready to get on a program or who sort of know that the way that the child protection situation is going to go, is going to mean she's not going to be able to go home with them, they often will leave. I do want to comment on the 100% certainty that a baby will be treated for NAS if mom is also using marijuana. I disagree with that. We have a lot of moms that use marijuana, and sometimes they need treatment, sometimes they don't. I'm very curious about your experience with that, because it just has not been my experience. And yes, the asset deposit, that's a really great sort of, I think, way of thinking about it.
We have some other questions. Abby commented again, can you comment on your experiences with nicotine as part of the polypharmacy? It seems like this exacerbates, I can't say that word, exacerbates symptoms for babies significantly. And this is something I could counsel on antenally.
And antenatally.
Okay,
Yes.
say that word either.
Yeah. I definitely agree with that. The nicotine withdrawal tends to happen earlier. So you tend to see it in that, in that initial sort of 24 hours. I think it probably complicates baby's course for longer than that in a lot of ways, some of which have to do with growth and placental insufficiency, some of which have to do with, polycythemia, or a little bit more hemoconcentrated babies that then have a tendency towards hyperbiliary, that then need lights, and NAS babies hate lights. My best advice on phototherapy and babies going through NAS, which a nurse of ours actually came up with, is to treat them below the treatment threshold and before their withdrawal gets too badly, and do it with Billy blankets, so that you can potentially spare that baby needing to be naked under lights, because it's going to make everything worse.
Yeah. Let me just point out, from now on, we're going to avoid the word exacerbates, Abby, because she clearly, that's a problem for her. So no more exacerbates. There's a question from Rebecca about, she said, I'm sorry if I missed this, but it was mentioned a lot of patients are Native American in your area. And actually, Erin and I have actually been up there and viewed your area that you work in. It's been 6 or 7 years, but beautiful facility. But with the patients that are Native American, what cultural considerations are used, offered, requested from patients?
Yeah. So I think the biggest, by far most important thing is recognition of historical trauma and mistrust of the healthcare system. I think there sometimes is a tendency to sort of be culturally responsive by trying to participate in a culture that's not your own. And I think it comes from a really good place, but often isn't real helpful, in the sense that, like, we do have policies at our hospital that, if families want to do smudging ceremonies, if they want to burn sage, other things, we have policies that make that possible. And we really want them to drive that. We want families to drive that. And we have Native advocates that can come in. We've had, where we've been able to have people that have doulas from the Native community, which I met with a group of Native doulas recently, and it was wonderful. That's been really helpful as far as advocating for moms. But the thing I try and emphasize with sort of cultural responsiveness is recognizing the impact that the person's culture has on them, and recognizing the impact of the way in which they've been marginalized, I think, is our first job. Things like sort of making token gestures towards sort of participating in their culture, I think, is much less important than recognizing all the other stuff.
Just a quick question about kind of how you do things, because, xylazine, of course, has been around quite a bit. And actually, in the center part of Minnesota, we've had quite a few xylazine deaths, or let me say this, associated deaths with fentanyl. Are you not sending off that blood for xylazine until maybe you have a baby that's just not acting like you would expect, like things are not or do you do it right away if it's a
We
fentanyl
do it
baby?
right away. Because of how prevalent fentanyl has been, we started sending, and actually like far less recently than you would think, or far more recently than you would think, we started just automatically sending fentanyl when we do urine drug screens. Xylazine, we have also now just been sending
Routine.
routinely. And that's all on our confirmatory testing, which is also a really important thing. That one, I think we do UDS is way too much and for dubious reasons, but also, the fact that these are on confirmatory testing is helpful, because then we actually know based on gas chromatography that it really is that, and it's not a false positive.
Okay.
I have a question. We work with a lot of folks that are in rural settings, and something that I've heard as sort of a repetitive theme is just hesitancy and lack of buy-in from staff to implement the ESC versus the Finnegan because they don't have a NICU or advanced level of care, nearby. Any words of wisdom or a little elevator speech that you've used to give quick buy-in?
Oh, I think quick buy-in is maybe the most important part of the elevator speech. And I absolutely fell prey to that when I came as sort of an outside person that was young and wanted to change everything immediately. That realizing that those things take time. I think the biggest things for us that help with buy-in was acknowledging that it was going to be hard at our facility to do this, taking suggestions and making it clear that we were open to continually adjusting things as especially nursing noticed, ways in which it was difficult, acknowledging nursing trauma, and then also talking about eliciting what their fears are and talking about safety. So there often is sort of this vague fear that well, what if something terrible happens? Okay, well, what is the terrible thing that you're imagining happening that would happen so fast that we'd be in trouble? One of the things that comes up is seizures. Well, it is actually unbelievably rare for babies to seize from withdrawal. And it would usually be a baby that is so symptomatic that they probably wouldn't still be at the place. So kind of, and, contextualizing that, yes, it can be hard to see a baby with some symptoms, but it is not a benign thing to give morphine, and it is not a benign thing to separate baby from mom. We think of you're protecting the baby, what's the downside? There is a very real downside, both psychosocially and medically.
Perfect. Well, we're about out of time. Anybody else with another quick question that we can throw at Rachel before we let her go? I can't tell you how much we appreciate it, Rachel. You guys got quite the program up there. And I have to say, even though years ago we were there, it was very impressive, your floor and your facilities for, the patients that you're working with. So really, really appreciate all the stuff you do up there.
Well, thank you so much.
All right. Well, we will let everybody get back to their day. And thanks so much for everybody coming. And Rachel, I hope you come back someday and have another talk for us. It was just a great talk. So thank you.
Thank you. Oh, hello.
Oh, and there's the baby.
He's not impressed.
He's very happy about this. Thank you
More
guys.
attention. All right. Well, have a good week, everyone. Take care.
Thank you.